This rotating 3D model maps the lumbosacral plexus, a network of nerve fibers formed by the anterior rami of the L1 through S4 spinal nerves, and it dictates the movement and sensation of the entire lower limb and pelvis. That single interconnected web is responsible for innervating a massive anatomical territory. It supplies the lower limb, the structural walls of the pelvis, the perineum, and the gluteal region. When you view these 10 overlapping nerve segments without an organizing framework, the sheer density of the crossing fibers appears chaotic and nearly impossible to untangle. To demystify this network, we build our map around the physical terrain they navigate, the psoas major in the lumbar region and the piriformis in the pelvis. By mapping where the nerve roots intersect with these distinct muscular landmarks, we can abandon rote memorization. Understanding the spatial routing is what allows a clinician to accurately trace a patient's distal leg pain back to a specific structural pinch point in the spine or pelvis. We begin with the upper division. The lumbar plexus is formed by the anterior rami of L1 through L4, pulling an occasional root contribution from T12. In this semi-transparent vector graphic, you see the psoas major muscle serving as the spatial anchor. The L1 through L4 nerve roots merge and form the plexus directly within its belly, making the borders of this muscle the exit gateways for the nerves. Moving from the top down, the first two branches emerge laterally from the psoas. These are the iliohypogastric and ilioinguinal nerves, both carrying L1 fibers. They route outward to supply the internal oblique and transversus abdominis, as well as specific sensory regions of the abdominal wall and external genitalia. The genitofemoral nerve, utilizing L1 and L2 roots, takes a different exit. It pierces directly through the anterior surface of the psoas major, descending to split into terminal branches that supply the cremaster muscle and the delicate skin of the upper anterior thigh. Pulling from L2 and L3, the lateral femoral cutaneous nerve resumes the lateral exit pattern. It leaves the psoas, crosses the iliacus muscle, and heads toward the lateral aspect of the thigh to provide sensory coverage. The internal geometry of the psoas major physically isolates these minor lumbar nerves. Because they form inside the muscle tissue, the angles at which they pierce the psoas dictate their exact exit vectors toward the abdomen and upper leg. This brings us to the largest branch of the lumbar plexus, the femoral nerve. Pulling thick root contributions from L2, L3, and L4, it emerges from the lateral border of the psoas and passes deep beneath the inguinal ligament to enter the thigh. The femoral nerve commands the anterior compartment of the thigh. It delivers the motor supply required for hip flexion and knee extension, driving the quadriceps femoris, the iliacus, and the sartorius. Observe this biomechanical leg model. When a patient suffers a femoral nerve injury, the leg cannot extend at the knee against gravity. Without the quadriceps firing, the structural integrity of the joint's mechanics collapses, resulting in severe weakness and a loss of the patellar reflex. Alongside this motor failure, the patient experiences a precise sensory deficit. Sensation is lost over the anterior thigh and via the saphenous branch down the medial side of the leg and foot. The other major L2 through L4 branch is the obturator nerve. Instead of exiting laterally, it emerges from the medial border of the psoas major, diving deep into the pelvis to pass out through the obturator canal. The obturator canal acts as the physical gate to the medial side compartment. Because the obturator nerve supplies muscles like the adductor longus and gracilis, an injury here compromises the patient's ability to adduct the thigh. Structural bottlenecks also create sensory syndromes. If the lateral femoral cutaneous nerve is compressed as it passes beneath the inguinal ligament, the patient develops moralgia perispetica, a condition marked by pain and numbness isolated to the lateral thigh. When a patient presents with anterior or medial lower limb deficits, the true problem is rarely in the leg itself. These mobility failures are the downstream symptoms of nerve entrapments occurring higher up, specifically at the inguinal or obturator pelvic gateways. To follow the neural pathway further down the limb, we have to shift our spatial focus deep into the posterior inner pelvis. This is the transition zone where the upper lumbar and lower sacral systems integrate. In this vector graphic, watch the L4 and L5 anterior rami isolate and merge. Together, they form the lumbosacral trunk. This Beck nerve bundle drops inferiorly into the pelvis, forming the crucial structural connection between the two systems. As the lumbosacral trunk drops, our second foundational anchor locks into position, the piriformis muscle. The sacral plexus forms directly on the anterior surface of the piriformis, incorporating the lumbosacral trunk alongside the S1 through S4 anterior rami. By connecting L4 and L5 down into the sacral roots, the lumbosacral trunk guarantees an uninterrupted continuum of motor and sensory coverage, bridging the entire gap between the lower abdomen and the distal toes. Just as the psoas major dictates the lumbar exits, the piriformis dictates the sacral routing. The superior gluteal nerve, carrying L4 through S1 fibers, leaves the pelvis through the greater sciatic foramen by routing strictly above the upper border of the piriformis. It travels to the gluteus medius, the gluteus minimus, and tensor fasciae latae. These muscles are responsible for abduction and medial rotation of the thigh, making them the primary stabilizers of the pelvis during a working cycle. This mechanical vector illustrates a positive Trendelenburg sign. When the superior gluteal nerve is completely injured, the stabilizing muscles fail. As the patient lifts the unaffected leg during a stride, the unsupported side of the pelvis tilts downward, resulting in a dropping gait. Below that, the inferior gluteal nerve exits inferior to the piriformis. Pulling from L5 through S2, it isolates its motor supply to the gluteus maximus, providing the force required for hip extension, climbing stairs, and rising from a seated position. The sacral plexus also routes nerves back into the core. The pudendal nerve, utilizing routes S2 through S4, leaves the pelvis through the greater sciatic foramen, only to immediately hook back inward around the sacrospinous ligament and re-enter the perineum through the lesser sciatic foramen. The pudendal nerve operates as the principal nerve of the perineum. It exercises strict control over the external urethral and anal sphincters, governing physical continence as well as sensory and motor sexual function. The distribution is functional. Nerves exiting the greater sciatic foramen secure bipedal stability via the gluteals, while nerves hooking back through the lesser sciatic foramen secure pelvic floor continence. The remaining fibers of the sacral plexus converge into a single massive trunk. Pulling roots from L4 all the way through S3, the sciatic nerve forms as the largest nerve in the human body, exiting the pelvis directly inferior to the piriformis. The sciatic nerve descends straight down the posterior thigh. Before it even reaches the knee, it provides the motor supply to the posterior compartment, contracting the semitendinosus, semimembranosus, and biceps femoris, the hamstring muscle group. This cross-section shows the root pathology of sciatica. If a lumbar disc herniates, or if an inflamed piriformis muscle physically compresses the thick sciatic trunk as it exits the pelvis, the patient suffers pain radiating from the buttock all the way down the leg, accompanied by mechanical weakness in the lower limb. When the sciatic nerve finally reaches the apex of the popliteal fossa behind the knee, its unified structure ends. It bifurcates into two distinct terminal pathways, the tibial nerve and the common fibular nerve. The tibial nerve continues directly down the posterior leg and onto the sole of the foot. It assumes responsibility for the posterior compartment of the lower leg, driving the mechanics of plantar flexion and toe flexion. Meanwhile, the common fibular nerve wraps laterally around the neck of the fibula. It then splits. Its superficial branch fires the fibularis longus and brevis to evert the foot, while the deep branch supplies the anterior compartment to power ankle dorsiflexion. Watch this stride sequence. The common fibular nerve is exposed as it wraps around the knee. If it sustains a severe crush injury or compression, the patient loses the ability to dorsiflex. The foot remains stuck in plantar flexion and drags across the floor, a clinical condition known as foot drop. To compensate for a paralyzed anterior compartment, a patient suffering with foot drop is forced to alter their biomechanics, utilizing a high stepping gait to lift the entire leg and ensure drooping toes clear the ground. These distal mechanical failures are the predictable consequence of an interrupted pathway running from the L4 through S2 roots down to the fibula. Stepping back, the functional macroarchitecture of the system is clear. The lumbar plexus, rooted in L1 through L4, acts as the primary controller for the anterior and medial zones of the lower limb. In direct contrast, the sacral plexus, pulling from L4 down to S4, dominates the posterior limb, powers the gluteal stabilizers, and dictates all distal foot mechanics. This data table overlays the completed 3D model. Every major nerve, from the iliohypogastric at L1 down to the pudendal at S4, traces back to specific root values, but the names and numbers alone are insufficient. Clinical diagnostic accuracy depends on visualizing how these nerves interact with their physical environment, how the femoral passes under the inguinal ligament, or how the gluteals route around the piriformis. In this final rendering, we can see the system for what it actually is. The lumbosacral plexus transforms individual central nerve roots into a calibrated distribution circuit of motor and sensory lines. Internalizing this topographic map is what separates rote memorization from genuine structural intuition. When you know exactly where the wires run, you can always isolate the short circuit.